Richard's professional background is social work, and over the past 35 years has worked in a variety of roles, including as a Director of Social Services and Health Authority Chief Executive.
Well, anyway, it's a pleasure to be here. I've been following the tweets. TLAP 13, if you don't tweet, it's never too late to start. And yeah, so it's good to be here. Any Wolves fans? Fellow Wolves fans. Well, consolation is it could be worse. We could be at the Hawthorns, couldn't we? It really would be beyond the pale. So, what do I want to do? There's a point when you're doing a presentation and the first slide appears and it's not the slide you expect to see. There's that momentary panic of have I loaded the right slides? And I think I have actually. But seeing as this one is up, this is very interesting. Let me tell you something about it. This is a question that the British Social Attitude Survey did about how people view different parts of the NHS, and we got them to put a social care question in. And I'm sad to say, folks, that social care is languishing there at the bottom of the pile in terms of, only 30% of the general public, so not necessarily people who use services, were very or quite satisfied. And I was shocked, I was truly shocked to see people rate their dentists more highly than they do social care. It's remarkable, isn't it? I mean, we've got personalisation. What have dentists got? Laughing gas, maybe. I don't know. Anyway, enough of this. I just want to say a few opening comments about personalisation, where we are. I want to talk about some of the big changes that have happened in the landscape of social care over the last 30 to 40 years, and some of the trends that are continuing. And really the implications of that in terms of some of the big questions we need to ask about what kind of health and care system we need in which personalisation can flourish. And that will lead on to say something about the Barker Commission, although I don't wholly want to turn this into a PR opportunity for the Commission. I'd like to say something about it, but I'd also like to send you away with lots to think about. And I hope I will leave some time for questions. Before I do, though, I was really pleased to see that the conference is called Personalisation of Health and Social Care. And it's disappointing, I think, that NHS turnout is so low. And that's a shame, because I think some of the big worries and concerns in the NHS at the moment, after the dreadful things that happened in Staffordshire Hospital, in Morecambe Bay and in other places, their discussions, their debates, their worries about how does a big, massive organisation like the NHS provide safe, dignified, quality care to individuals, not just disease groups or the fractured femur in bed 6. And it seems to me that the issues about how do we provide individualised care to frail older people in the busy environment of an acute hospital are really questions about personalisation. Debates about how the NHS needs to dramatically raise its game in getting better health outcomes for people with learning disabilities should be a debate about personalisation. And I think there's a great deal within the social care sector that we've learned that we can share with NHS colleagues. So I just wanted to make that point first of all. The second overall point was really about the financial context, and this slide illustrates that real-term spend by local authorities on adult social care is falling, and the latest stats that were released suggest that there's been a 5% drop in spending since 2010. And I don't want to harp too much on about the money. You know how difficult it is out there. I was introduced as someone that's kind of been doing this for 35 years, and from my point of view, personalisation, I think, is one of the best ideas that we've had in social care over that period, if not the best. But this is the point. We're trying to implement the best idea at the worst possible time in terms of money and finances, and that is a real problem for us. And this next slide kind of goes into it in a little bit more detail. Now, spend both on older people and working age services for working age people is falling. Numbers of people using services are falling, especially, and this is quite worrying, I think, in community settings. There's place for a discussion in another place at another time about some of the trends behind this. But I think it is quite remarkable, really, that so much progress in personalisation has been made against this pretty tough backcloth. So what we're trying to do, I think, is make personalisation work in a very, very cold and hostile climate. And there's two dangers, two perils that I want to highlight. The first is that personalisation becomes the fall guy for cuts in services, or alternatively for changes and even closure of services that actually should have been sorted out years ago. And that personalisation takes the rap for that. The second danger, which I think is even worse, is that we use the financial climate as an excuse to postpone, to slow down the pace of progress, rather than as the reason that we should promote it. Because I think we're becoming increasingly clear in terms of evidence that people are more likely to get better outcomes if they're in more choice and control over their care and support arrangements. So we need to press on, difficult though it is. So those are just a couple of observations. I think we all agree that we want personalisation to be at the heart of the reform system, but I want to put to you that I think we need to pose some bigger questions about what that system should be. And that's why we've established the Barclay Commission. Some big changes have happened. This is the change about the older population. I'm always wary about slides that show the impact of an ageing population, because I think overall an ageing population is a good thing. It's something we should celebrate. There are lots of opportunities, but it does pose challenges as well, particularly about the old and how we respond to their needs. And a particular issue about ageing is that more of us are going to live to get dementia. And dementia poses some particular challenges to the current system that we've got, because although it's a clinical diagnosis, a lot of the needs are related to social care rather than medical interventions, and sometimes people ping between the two, and sometimes they get stuck in that horrible border sort of land in the middle. So lots of issues about that. So dementia is a big issue. And more of us are going to be living on our own. And the way that we've relied on carers and informal carers in the past, we can't necessarily assume that there will be as many people to care in the future and to take the strain of the deficiencies in our current care system. So that's another trend. Another big change, I think, is the accelerating numbers of people with long-term health conditions, and this is often working age people as well, not just older people. And what's new about this is that is the mixture of health and social care needs that will arise from some of that. And this is big business in terms of the NHS. People with long-term conditions represent about 50% of GP appointments, 64% outpatients, 70% of inpatient hospital days are connected with, are represented by people with long-term conditions. So it's a big issue. And another factor as well that I think has been, hasn't really been on the radar until quite recently is this overlap between physical health problems and mental health problems. And we reckon there's around a 30% sort of overlap between people with a long-term physical condition who also have a significant mental health problem. Yet our health services still treat people in a separate physical health silo and a mental health silo. So that's another dimension that we have to take into account. This is the slide that will get you all shifting nervously in your seats, because we're actually storing up quite a lot of problems because our lifestyle is not that healthy. And it's all right, folks, because none of this is about you. This is about people who sit on the sofa all day watching the Jeremy Kyle show, eating junk food. And none of us here need to worry about how many units of alcohol we drink, do we? Of course not. No. But seriously, many would say, quite apart from the health and care system, it's what public health and prevention and well-being strategies, what impact they will have on some of this. to reduce the demand for health and care in the future. And that's the bit that we've really got to get right, and I think we probably have. And I think well-being has come up a few times today, hasn't it? Because otherwise, we see these eye-watering statistics about more of us are going to get some of these conditions, and it will generate a lot of health and care needs, and for longer, because modern medicine has discovered the capacity to keep us going for longer with some of these things. So hence life expectancy. So what does all this mean? It means that we have to rethink how and where care is provided and delivered. At the moment, the default model is based on the notion that we get ill, we have one thing wrong with us. We go into hospital, we get fixed, we come home again. Whereas the challenge for the 21st century health and care system is how do you provide long-term care, not single episodes of care, long-term care, close to home, coordinated across a range of services, professions and so on, making use of technology and giving people much more choice and control. And that's a far cry from what we've got at the moment. And before I move on, I just want to say something about workforce issues. And this shows actually, I mean, we often think in social care that we're the kind of junior partner to the NHS. And look at these figures, 1.6 million social care employees, another 3 million at least in voluntary work. We could add on to this, I'm not sure why we haven't got this on this slide, 5 to 6 million informal carers. And against almost all metrics, the social care sector is actually bigger than the NHS, apart from one, and that's money. Which unfortunately is that one, isn't it? It would have to be that one. It's bigger. So, we've got a bigger sort of set of issues here. 1 in 10 of the working population works in health and social care. So, this is a significant workforce set of issues there. I want to move on now and just look quickly at the way the service landscape has changed. And this shows, go back to 1980. If you can, well, you can see this. This shows what's happened in terms of independent sector provision, which exploded during the 1980s. This is residential care, this is nursing care. It exploded. This was a period in our history, actually, where the state did write a blank cheque for social care, but only if you needed it in residential and nursing care homes. And the bill was out of control. Government capped it, transferred it to local authorities in '93, and you can see it start to plateau in the case of nursing homes fall. But the 2 points I really want to make here, I mean, there's this silent transformation in services, and where we've got to is that around 90% of all care provision now is delivered through the private sector and voluntary organisations, but mostly private. We haven't thought through the consequences of that. We have sleepwalked into a situation. And only recently, only after 20 years of this mixed economy, have we thought about what arrangements we need to put into place to manage and oversee the market. Southern Cross, an extreme example of that. Not so much a case of closing the stable door after the horse has bolted, but in some quarters not recognising that there was a horse in there in the first place. I thought that might get a laugh. I spent a long time thinking that. So we've got this kind of private sector dominated pattern of provision. We haven't thought through the implications of that. The other, which is more insidious, is the way that the NHS here has kind of virtually opted out of long-term care. And what that means in practical terms is there are a lot of people now in nursing homes who 30 years ago would have been in a long-stay NHS bed. They're probably getting better care in a nursing home, but they're probably paying for it. And these things have happened without any sort of explicit debate, any transparent discussion. We have kind of drifted into this situation. And it means, particularly in relation to the health changes, that the boundary has shifted. A lot of people who would have been receiving free healthcare, free at the point of use, are now into that means-tested system. It is tipping back again. Continuing healthcare numbers are going up rapidly, increased by about a third in the last 4 to 5 years. And continuing healthcare is what I describe as a scar on the face of our modern health and social care. system. If you go onto our website and our Barker Commission web pages, read Ray's story. And this is a story about a man who was dying, and his people that loved him went through hell basically because of assessments and funding and disputes and aggravation. And it's shocking that our system does this to people. And I think this is one of the worst kind of places in terms of needing to do something about a system that deals out rough justice. And it's a bad place for people that find themselves in that situation. It's also a bad place for professionals who have to do these assessments and make the judgment of Solomon. So, you know, a lot of changes there that have really kind of crept up on us and we haven't thought through the consequences. And one of them, of course, is that more and more people are paying for their own care because they have property wealth on a scale that the architects of the system in 1948 could not have imagined. So what we've got now, in effect, is that, whereas in 48, NHS established as a free at the point of view service, social care was funded, social care was funded separately through means testing, and in fact 43% of people in care homes now fund completely the full cost of their own care. If you add in third-party payments and top-ups, it's 57%. And again, we've not had a debate about this. The Dilmont reforms kind of almost, you know, cement the fact that everyone's got to pay up to a certain limit, but we've had no real debate about that, and I suspect most people are still in the dark about that. So, and we've ended up with a system really of social care budgeted 1/6 of the NHS, not that it's a competition, but actually if we were starting from scratch, I think what we'd probably be doing is investing in a really good system of care and support, system that promotes well-being, promotes independence, and a system that is supported by healthcare. Whereas it feels we've got it completely the other way around, and that we've got a relatively small, definitely underfunded care and support sector supporting this big NHS monolith. And I think we want to do it differently if we were wanted to start all over again. So in summary, there are more of us living longer, more things wrong with us, and that's the point I didn't make actually. We have underestimated the extent to which older people over 65 have at least one thing wrong with them. Pointy-head people call it comorbidity. And we've underestimated that. Traditional model of care is based on acute treatment, it's reactive, it's crisis-driven. We've had this shift from a public to private delivery of services without any explicit or transparent debate about the implications of that. And there's been a very substantial shift to private and co-payment funding of care services, whilst the NHS remains largely free at the point of use, and I think that is a hallowed principle. So who pays for what is ad hoc, it's arbitrary, it's confusing. If you're in a nursing home, there could be at least 4 ways that can be paid for. Now, don't ask me to describe them all because I'll get confused myself. But it also raises questions about the sustainability and equity of these two separate systems. There's important questions about where the money comes from. And so what that means in upshot, and now we're getting on to why we have established the Commission, is that if you've got a clinical condition, if you've got a sort of cancer, for example, or another long-term condition, the offer from the NHS is very, very different to the offer from the state is very, very different to the offer that you get if you've got purely care needs. And really this goes right back to 1948. This big, bold, inspiring vision of healthcare free at the point of use that everybody, rich and poor alike, would use. 65 years later, it still grips the public imagination. The nearest thing to a religion, is how Nigel Lawson described it, thus displaying a somewhat shaky grasp of ecclesiastical history. There we are. The nearest thing we've got to religion. Yet social care, the National Assistance Act was really, I mean, it wasn't on the radar. I mean, it's a different set of expectations. People didn't live all that long enough to get the lot of social care needs. And if you could read the text on that, it says the opening words, an act to terminate the existing poor law. And the care bill does take us a long way in legal terms from that. But this is why we've had this kind of two-speed set of issues over the last 65 years. And, you know, there wasn't really a settlement for social care, actually, if we're honest. There wasn't really a settlement for social care in the way there was with the NHS. And because of all the changes that have happened, we think we need to kind of look again. And I think the architects, you know, of the 1948 changes, you know, they would be appalled if they knew that 65 years on, you know, 57% of people were paying for their own care needs. It wouldn't have occurred to them that many people would either need that much care or have the resources to pay for it. We are moving on, I think. I mean, some steps forward. I think it's great that we have a new narrative around integrated care that is very like steeped in the blood of personalisation, isn't it? This very person-centred, coordinated care definition. That's really good. And there's lots happening on the integrated care front with Pioneers, the Transformation Fund. You know all about that. And I think these are good steps forward. But I think we say that we need to go beyond that. And that's why we've established the Commission. I'll tell you who all these shady looking characters are in a moment. But to examine the way in which health and social care is organised and funded, whether the system can be better aligned to meet the needs of people, patients and service users. And there's three kind of questions really. Does that boundary that shifted over the last 65 years need to be redrawn? And if so, where and how? Is there any other ways that we can come up with getting away from this health and care dichotomy, given that, you know, most of us are going to have needs which straddle both? Should the entitlements and criteria used to decide who can access health and care be aligned? And that is a really tricky one. I mean, there is rationing both in health and in social care, but it takes place in very, very different ways. And is there a way that we can bring the funding together, but in a more coherent way that avoids some of these boundary disputes and boundary issues? And again, there's lots of issues around that. I did say the importance of getting, oh, there we are, technology, right? Okay, so, I mean, I don't really want to go through the Commission. Our Commissions are in great detail. I think we're really pleased with the group that we've got, chaired by Kate Barker, who's a very experienced business economist with a particular expertise in housing. And we chose her because she didn't have, and she wasn't steeped in health and social care, bring a fresh and independent mind to it. And we've, you know, got a load of really strong people with different backgrounds. Jeff Alltime's got a lot of history both in health and local government. We're delighted to have Michael Bishard, who chairs Sky, and lots of experience, Julian McGrant. And we've got this really interesting guy, Mark Pearson, the Organisation of Economic Cooperation and Development, who heads their health division, and he's contributing all sorts of ideas about how other countries tackle some of these issues. And then it's myself and Nick Timmins, my colleagues, who's supporting the Commission. So we're a bit busy, actually. So the call for evidence closes at the end of this week. That is part of it. I mean, we're really keen for people to give us their ideas. But we are going to be doing a lot of public and stakeholder engagement over the autumn. We're going to be doing some stuff on Twitter. And the Commission would like to appoint some experts by experience to tell them from their experience what are the issues and to explore possible solutions with them. I think that's an important step forward. So we're into engagement, into evidence gathering, both at home and abroad. Aim to produce interim report in the spring, final report autumn. Now this is really important because that timing is to land the report just in time for party conferences and to influence the debate in the run-up to the general election. And from Kingston's point of view, it is pretty determined to do what it can to really get some of these issues up the agenda and help the politicians to take them seriously, so we can have a proper public debate about some of these issues. I'm conscious that I'm probably rapidly running out of time, so I'll bring this to a close. So there's some details, and I'm hoping you will have these slides in some shape or form. commission hashtag, some really interesting material on the website. So I think that's probably all I want to say at this point. I mean, we recognise we've set this commission a really tough set of exam questions. Really difficult, very controversial potentially. The tradition in this country is to muddle through rather than embrace big radical change. So they're going to need all the help they can get. So I do hope you will get involved in this. I think if we really want personalisation to be truly effective and meaningful, we've got to sort out some of these bigger questions. Most of us in this room at some point will be users of health and care services, so we're doing this for ourselves, for our own families and communities, and for the people that we serve. Thank you very much.